I'll be ready in 20 seconds. It's going. Okay, we're live. Go ahead.
Okay, Fanny, as soon as you hear the recording,
Okay.
you can start.
Okay. Thank you, everyone, for being here today. I would like to call this meeting to order. And the first thing is to approve the agenda for our last meeting. I would like to see if there is a motion.
Approve the minutes, you meant, right?
So moved.
Yeah, approve the minutes.
Second?
Okay. All in favor?
Yes.
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 Anyone opposed? Anyone abstain? The meetings are approved. Thank you. And the first thing would be the report by Matt.
So I'm going to start and then hand off to Matt.
Okay.
So good
So,
morning.
Eric.
Good morning.
Thank you.
Yep. So good morning, everyone. This is our strategic planning subcommittee of the board, and what we're covering is Q4 fiscal year 2020, April 1st, 2020 through June 30th, 2020. And as I don't need to remind everyone that that was a very difficult time for New York City Health and Hospitals, New York City, with the COVID-19 surge. There was significant decline in non-COVID-19 volumes. Our inpatient volumes actually dropped by 64% in non-COVID as they were replaced by COVID patients. We also saw shifting utilization patterns across, on top of that, we saw city and state budget challenges, which we're still in, and new operational priorities in this post-COVID pre-vaccine period. The system fiscal year 21 budget reflects focused interim post-COVID strategy, and early results show continued operational improvements and value. And so we're going to update on our performance, organizational health, outline planning and monitoring processes, and reassess priority measures for the board. Going to the next slide. So this is follow-up from our meeting last time in terms of wanting to incorporate equity and access into our strategic pyramid. And so we took all the feedback, the great feedback that we received from this board or committee, and we integrated it into our vision statement. So to be a fully integrated, equitable health system that enables all New Yorkers to live their healthiest lives. And on top of that, we added a foundation to the bottom of the pyramid in the dark blue that shows social and racial equity. And that was based off the feedback that making its own strategic pillar wouldn't show how important it is to all of our strategic pillars and everything that is above it in the pyramid. So wanted to bring this back. And I'll pause here. Any questions, comments on the strategic pyramid and equity?
Thank you, Eric. Any comments from any of the board members? Jose?
No, it looks great. And I'm glad that we are doing this and putting all these elements front and center. So thank you.
Thank you, Jose. Sally Hernandez Piñero?
No questions. Thank you.
Thank you. Frida Wang?
No questions. I think this reflects well our discussion. I like the foundation of social and racial equity. So thank you.
I would second what Frida says. I would like to thank to you, Eric, and also Matt and your team for listening carefully and really ensuring that this pyramid captures who we are and what we are all about and how we believe we best serve our patients and our communities. Thank you so much for doing such an amazing job. And I would like to thank your committee for looking at it and really coming up with a communication of this pyramid of values in a way that is clearly understood and everybody see the alignment. Thank you.
Thank you, Fenny, and I just want to give credit where it's due. Our Equity and Access Council took this up, made suggestions, and then to Ana Marengo's communications team, there were the graphics behind this beautiful pyramid. So, okay, I'm going to
Thank you.
move to the.
And now I do have a question, Eric. Eric, I do have a question. Now, one of the things that pre-pandemic we did quite a bit, Sally, Jose, and Frida, was to visit different hospitals, different facilities, and we saw kind of the pyramid posted in certain locations. They were referred to. What is our plan to disseminate this new layout of the pyramid and having conversations with all the different units on this kind of new communication strategy of our values?
That's a great question. We'll work with Anna's team, who helped us communicate out the pyramid about a year and a half, 2 years ago, and when we first launched it. And I think we'll follow a lot of that same strategy with screensavers, arming kind of our CEOs and facility leaders to in all different types of formats, so that they can share it widely too within their leadership meetings, down to their unit departmental huddles. That's the goal.
And the CAP members also, because we saw it in all different facilities, a prominent place of communicating the eye care kind of value system. So thank you for sharing that.
So going to the next slide, I think this came from a little bit of, right, we have so many subcommittees of the board that all feed up to the full board. How do those kind of integrate seamlessly with our strategic planning as a system, but also the strategic planning subcommittee of the board? And we just wanted to share how we operationalize what's shown in that pyramid. And so there are 4 kind of major kind of processes, governance structures that feed into not only Dr. Katz's strategic planning committee, his leadership, but also this strategic planning subcommittee. And those 4 are the annual finance plan and facility budget process. This is led by John Olberg, finance, Matt Siegler, patient growth, the key pillars. And this is just, right, all 4 of these touch on all 5 pillars, but maybe more so the financial sustainability is the key pillar here. Capital and IT planning, led by Christine Flaherty, Kim Mendez. The key pillars all is cross-cutting. Stakeholder feedback, community health needs assessment, which has been brought to the board by One City Health and MMPA. Also, Deb Brown, external regulatory, plays a major part in this, or a lead. The key pillars here: access to care experience. And then the clinical services planning, led by Michelle Allen, Dr. Allen, MMPA. This one also is cross-cutting, but we wanted to call it access to care experience, quality and outcomes, and culture and safety. So wanted to put this on paper and show how it kind of all flows into this meeting, as well as Mitch's bi-weekly strategic planning committee. Any questions on this?
Any questions, Jose?
Thank you.
Sally? No? Frida? I just have one, Eric. You all and the graphics team did such a wonderful job on coming up with a pyramid and showing. I would like to exhort the creative minds on the graphics to come with a way to present the interconnection of the pillars to these operational strategies. I have seen sometimes a chart that shows like the pillars, instead of being pillars, will be like kind of beans, and how they flow into the different operational strategies. So there may be a way to present this in that is kind of aesthetically kind of aligned with the pyramid. So I just say, like, maybe the graphics team can take a look and use their creative minds to come up with a way that only by one person looking at the graphics immediately they see the interconnection and how we are kind of making real those values and those pillars into actionable items.
So Fenny, you totally busted me. I created this graphic, so that's why it doesn't look as good as the pyramid. But in my defense, you should have seen Matt's attempt at creating a graphic. So this is an upgrade. But yes, we
I
will.
want to see that one.
We will. We will
No,
ask our
no. You
graphic
did a great job,
designers to do a
Eric.
better
You did a
job.
great job.
Slander. It makes total sense when it's hand drawn and there's squiggles.
Okay, I'm gonna turn it over to Matt, starting on the next slide.
Thank you.
Eric, thank you, Eric. Despite having no respect for abstract art, I will take it from here. So what we wanted to show is the processes Eric outlined on the prior slide. This is a reflection of some of the output of that work at Mitch's senior leadership team. Our conclusions first in late 2019 when we reviewed our ongoing strategy, and then in May of this year as we were finding our way out of the COVID surge period, were largely the same with some additions. This reflects our thinking as of May. We really did feel like the current strategy has worked. It's been a successful 3-year period for health and hospitals. And the key successes we identified over that period, first and foremost, were our unified electronic health record for the system. Just a critical thing for clinical care, financial success of the system, and integrating the system together culturally. The financial improvements that we've seen, beating our budgets in past years and success on multiple fronts there were obviously key. Improving culture around the system were critical for us. Eric has been such a terrific leader on that, and really, I think if you were going to put it in a single change, the change in mindset that the Health and Hospital Central Office serves our facilities and serves the people providing care on the front lines, rather than the other way around, is the key change I try to carry with me and my team every day. Next, it was shifting the system's focus in a new way and grown our primary care patients for the first time in a decade. So that's very exciting. Standardizing, or where appropriate, regionalizing services around the system, right? Making sure we are doing what we are best at in every location and system. Another success was continued innovation and citywide leadership on behavioral health and correctional health. Dr. Barron, Dr. Yang, just tremendous success there and continue to help us lead the way for the city. And then, of course, managing the COVID surge and even managing it internally to be able to help other systems around the city where necessary to take that leadership role. So, our conclusion were that the prior plan was working, but clearly with the reality of fewer in-person visits, the challenging city and state fiscal picture, and our central role in the COVID response, our strategy needed to adjust for FY21, and we needed to learn some key lessons from the strategic initiatives that weren't as successful. So the lessons we learned were to go further in setting clear ownership and accountability for specific projects, push even further on empowering, engaging, and developing our frontline staff. That service leadership mentality from central office, we have to continue to push that. The business planning and work plan process of building structure around our budget and our growth plans, we wanted to build on and deepen. I think the big changes that I've felt in that, and I think we've driven forward in FY21 more than ever, is building as many business plans and as much accountability into individual hospital budgets. So rather than having a single system-wide budget that really only we have in our heads at a central level, every facility knowing the expectation and the performance on key KPIs in their monthly budget meetings is key. So, and then I think the final lesson that is most important to carry forward is just what amazing things the system is capable of. We really did do 3 years worth of work in 3 months during the COVID surge, and carrying forward that sense of confidence and ability to work quickly has been key. So the key strategic priorities that we put in place for FY21, again, trying to stay focused given the uncertainty in the environment and continue to deliver very positive progress for the system. Clearly leading the test and trace program is at the top of the list. Helping the city reopen and avoid future surges and the devastation we saw in March and April is critical. The next priority, though, improving OR efficiency and OR volume, that's a key one of staying focused and trying to build operational excellence. I think Dr. Allen may speak to it in the M&PA committee, but I believe we're going to have the best year in surgical performance that we've ever had in health and hospitals, which is a tremendous thing to be at 90% on-time starts versus 60% pre-pandemic. So making that change coming out of a surge is I think, a great achievement. We are going to continue to focus on our value-based payment this year, especially building in some of the infrastructure to be even more successful there. Value-based payment makes us much more financially resilient in the face of volume changes and utilization changing patterns coming out of the COVID surge, so that's critical. And then the other pieces, I'd say, continuing to make progress on our revenue growth strategies, implementing our new contracts with our physician affiliates and our nursing and other partners, optimizing our express care to make those economically successful in the changing utilization patterns and with our new online platform. We're moving forward and making progress on the system-wide data and analytics governance process under Eric and Alex Izaguirre. Our more focused strategy around pharmacy with under Danielle Dabari, focusing first on an inventory management system and enhancing the pharmacies. So I think making incremental and critical progress to make sure our overall pharmacy initiatives are successful, even in the face of potential policy changes at the state level. And then the remaining four are, I'd say, evergreen for us, right? We want to focus as a public hospital system on patients that we are uniquely positioned to serve in partnership with the city and the state. So behavioral health, children and families touching the foster care system, homeless New Yorkers and the justice involved are critical for us. Christine's work around managing design and construction projects, building off the heroic work she and her teams did during the COVID surge, is an ongoing and long-term priority for the system. And we've got to continue to be efficient, reducing unnecessary administrative costs and improve the quality of care around the system. So those are they're large, but I'd say they are focused priorities for this year, and we try to balance long-term investments and success with the near-term needs and kind of can't lose strategies in a very unsettled time. Any questions on this piece before I move to the Q4 priorities?
Okay, Jose, any comments? Any questions?
I don't have any questions, Celine. Thank you.
Sammy?
Yeah, I don't know that these are in order of priority, but I would think improve in quality of care would be number one. Maybe it's just meant to incorporate everything above.
You're absolutely right. They're not in order of priority. They're sort of in order of what's shiniest and newest, right? The quality of care is the foundation. It's always the priority. It's fundamental to what we do. T2 and the OR focus are new for this year, right? There was no T2 in FY20 clearly, and our operating room focus was less in FY20 than it is in 21. So it reflects a little bit more of that, but you're absolutely right. If they were in order of priority, quality of care would be number one going away. And I'm not just saying that because I'm sitting next to our chief quality officer.
Love you, Sally.
Thank you.
Okay, Frida?
I think this is a really great, list of strategic priorities, and appreciate your commentary around it. And I think more actually when we get to it and talking about how do we track and measure on the dashboard and going forward, we'll maybe come back to this a little bit more, but I think this is terrific. So thank you for the summary.
Thank you, Frida. And actually, my question is kind of follows yours, in which, as I was, hearing and reading the priority list, I was thinking of what would be the goals, what kind of metrics we're going to be using, and how will we consider success, or that we have achieved success, which is a little bit unclear. I know that some of these are more quantitative, others are more qualitative, but we really have to find proxies to see how we are progressing, particularly if we wanted to look not just a year end, but we want to see it throughout the year, like quarterly. How are we in track? Are we ahead? Are we kind of need to emphasize and take the actions appropriately to bring it back to where we would like to, and also evaluate kind of somehow reflection of, okay, these are the priorities that we established. What else have we learned during the time? And that's one of the questions that we had, like during COVID. It highlighted certain areas of strengths. It highlighted certain areas of that we needed to work harder. And I think connecting that priority to that reflection of those may be interesting. So that will be one question, again, following on what Frida has mentioned. The other is that, and maybe it's my nature that likes to see the interconnection. I always tell people that I see life as a movie, not as a series of photographs. So I like to see the interconnection of how everything kind of starts and leads or influence. So there may be a way, since Eric, you're going to be talking to your graphical, to the creative minds, that we connect these strategic priorities to both the pyramids and the operational elements. Where are they connecting? That will be a suggestion, since they're already thinking about it, so that we can see clearly, okay, when we're looking at lead test and trace program, how is that affecting? Is that the quality of care? Is that financial? Is the access to care? Very likely it's access to care, but I think we want to take control of the narrative and don't necessarily leave open to people build those connections, but we communicate the connections. How do these connect to the strategic pillars, and how it connects to the operational processes that we have put in place to realize those strategic pillars. So that's my second question. The third question, and if you don't mind going back to the previous slide, if you don't mind, I think one more. Back. I think here, and I know that you are working very hard on getting all that, but since we already went through this process of adding this foundational value of social and racial equity, when we start talking about the strategic plan, I will suggest that we talk about the pillars and the foundation. Because they have to be all together. So right now we have 5, we need to be talking about 6, because the issue of social racial equity, what are we doing? And I know that you have done a lot of work on that in terms of how you classify certain tests, and how the tests are identified or connected to specific demographics or populations, and how that may influence the way that people see the results or their perception of going toward that. So I just think that as we already went through this great work of including this foundational value, that we put it as we go through for all the communication of the strategic pillars.
Great point. I think that last, I'll try to work backwards, and I think they're because they're all great questions. I think that is a excellent point, and we will integrate it both through graphics and in all our communications. That foundational, underlying or 6th pillar, however we want to frame it, is a part of this work and the lessons we've learned and where our focus is. I may have missed the second question, or I may ask you to repeat it. But in terms of reporting on progress, I think that's to me a great lens as we get to the dashboard here to look through whether this is the right forum and design for how we present on that, right? It is at this committee's discretion whether we want to report out on, 18 measures like that, or we could have a discussion on these priorities that we rate, where we're tracking month to month, quarter to quarter. And I think in prior versions of this committee, the reflection of 18 or 15 specific sub-measures should give us a kind of entry point to discuss how we're tracking on the broader priorities. But I think that's an important thing to discuss in this meeting. Did I miss a different question?
Yeah, no, the second one was on how to present graphically the interconnection between the strategic priorities, the pyramid, and your operational structure. That means slide 12, slide 13, and slide 16. How do you interconnect those three? Because to me, they are interconnected. We need to know how each one of those strategic priority really advances our pyramid, number 12, our pillars, and the mechanisms that we are using for that. That's slide 13. So those three slides, how do we, again, this is a challenge for the creative minds, how to put it in one slide, in one graph, those three elements of it.
It's a great question, and we will get it done.
Thank you. Thank you.
Penny,
Okay.
quick question on that. Are you thinking both about not only how do you visualize it, but how do you, for example, slice some of the indicators? Like if you go back to a previous slide, where one that had the indicators, so not that one.
Indicators.
This one?
I'm sorry, I'm missing it. Go back.
Back?
Be the positive.
Yeah, that one.
Positive trends.
14, yes, slide 14, yes.
I guess what I'm going is that we have indicators that tell us how well we're doing, but we, for example, don't integrate the equity lens into them, how much variation there is across any angles, facilities, different populations, and so on. Were you thinking about that, Fanny, also, or more than graphical representation of it?
I would say that's what I'm looking at, what I would like to get, but I also try to encourage to make it simple, like very simple. So that's where the graphic, it becomes important, because what I find with a lot of strategic plans and is that sometimes you almost have to read the whole document to get a good picture of what really is going on and the interconnection. So that puts a lot of overhead on everybody to try to be almost at the same level of depth than the people that are working in executing. And I think what we need to do is back up so that we can provide people like a 50,000 view that you can see how things are going. The whole issue of, are we in track? We say that we want an A. Are we in track to do A? And there are a lot of steps in the middle, but you don't have to represent all those steps, but give you a very high level view that you feel very confident that you first understand what is going on. And second, you feel that we are moving towards the in the right direction to achieve our goals. Does that explain, Jose, what I was trying to convey?
Yeah, no. I mean, I think I got it. That I mean, I always think about this as everybody at every level sort of align. How do you take a measure or a goal and take everyone in the organization at every level to sort of understand what that goal gets translated into my day-to-day, whether I'm a doctor, a nurse, somebody working in environmental services, it doesn't matter. But anyway, that's aspirational.
No, but Jose, what you're saying is very much aligned with what I'm thinking. It's only going to the different levels of operation, but also going to the different levels of the strategic level. So you have to go from the strategy to the tactical to the operational, and they all have to be aligned. And that's what I think we're trying to seek here. I think you and I are in total agreement.
Thank you.
Thank you.
Just
Matt
sharing along that. Oh,
yeah, Matt and Eric, I just want to say, I know that Jose and I we're chit-chatting on this, but
Oh, it's good.
you get a good view of what we're thinking?
yes, yes,
Yes.
and very much aligned with our thinking. The dashboard at this level, right? It tells Mitch, it tells our strategic planning committee, are we moving the needle on these 18 key metrics that we identified? But what does that mean to the CEOs and their teams? What does that mean to the service chiefs and the nursing directors of each unit? And what does that mean to the frontline staff?
Yeah.
So what we've done a lot of work with both our performance improvement teams, but also with human resources, is now right when they present projects at the QAPI committee, it follows those 5 pillars. It changes each quarter, right? This one's a care experience, and then quality and outcomes, and so forth. And that's what we're encouraging each of the facilities leadership to have a system or a facility level dashboard within those 5 strategic pillars. What are 2 or 3 key metrics? And then ask the ED director, what are the 5 projects that you're going to be working on this year that you're going to present out at the local QAPI, at the facility level QAPI, one within each of the strategic pillars.
Yeah.
We've actually modified our performance evaluation forms. So when I go meet with Mitch, it's no longer kind of these generic, broad, vague categories. It's within care experience, what were 3 goals that Eric set? Did he meet all 3 of them, or did he hit 2 or 3? And then why didn't we meet the 3rd one? Is more of a focused discussion around outcome measures within the strategic pillars. So we're moving in that direction. We want people to start thinking about what is my role as an individual in H&H to push in all 5 of these pillars or swim lanes towards the vision. And so very much aligned with what you and Jose were just talking about.
Thank you.
Great. So now we'll move into actual performance indicators for April through June. These are the positive trending indicators. I think, top of list, as I mentioned, is the unique primary care patients seen in the last 12 months is up to 445,000. That is an increase, as I said, for the first time in many years around the system. It's been a declining number for us. And so investing in new primary care capacity and really making that the front door to our system is a great indicator. NYC Care has launched citywide in 2020, and so the enrollment is above the 20,000 goal. That's terrific. Again, our overarching measure of financial sustainability, which is our patient care revenue divided by our expenses. So really the things that we control separate and apart as much as possible from policy changes at the state or federal level. A significant increase quarter to quarter. I expect this to dip back down towards prior quarters when unfortunately the severity and level of intensity of the COVID cases that we saw raised this up significantly. So I think we will return to a different level in the prior month. Similarly, the percentage of Metro Plus spending at health and hospitals, we're seeing an increase there. That's terrific. And we do expect some of that driven by the disproportionate share of COVID intensive care that we did, but the continued trend we think is positive. The percent who left our emergency departments without being seen dropped significantly in this period. Similarly, I think that's driven by just the lack of elective ER volume during this period, right? People were quarantining, people have stayed away from our emergency departments, the overall volume is down. And as the volume is down, the percentage of people who leave without being seen drops as well. The measure that is improving so quickly we can't even keep up with it on the slides here is the final one, our MyChart activations. We set a prior goal of 20% and then a stretch goal of 30%. As of June 30th, it was 20%. As of today, I think 41% around the system, which is remarkable. And I think we're looking into it, but driven a lot by patients coming in for tests around the system. So people sign up and get the results through MyChart, and it's really an entry point and a good sign of what you were talking about, Fenny, of the connections, right, between T2 and one of our other strategic priorities. So how do we help those folks who come in just for a test become a part of our system and connected to primary care? Next slide. These are our negative trending indicators during this period. The number of e-consults was down for the first quarter in a long time. Again, I think driven by many of our primary care practices and specialty clinics being at substantially reduced volume. The amount of elective outpatient treatment of any kind went down dramatically during this period around the city and the nation, frankly. So that's not a surprising indicator, but we do expect it to start climbing back up in subsequent quarters. The number of insurance applications submitted down dramatically again as people not coming in through the front door to get care. And the follow-up appointments after behavioral health discharge. This is a challenging measure in any quarter, but during a time when so many people were working remotely and it was harder to get folks out to follow up with people, we did see a dip. The hemoglobin A1C control measure dipped again in this quarter. I think we have pushed hard on this, and this is despite heroic work to get people, I think 2,500 people medication refills who were not able to come in for a visit. I think this was a challenged one during this time, and Eric can speak to more about where we're going with it in the future. And then not major declines on care experience, but declines on both of those during this period. The steady trends were one of our big IT, HR, and finance projects. Stayed steady at 80% complete, the ERP project. Sepsis, our sepsis bundle, which we'll talk about more later in terms of measures we might change, has been steady and above state indicators. And then our AR days per month, again, not where it needs to be, we think, because of COVID indicators, but stayed flat versus the prior quarter. And so this is the dashboard as it stands now. As we discussed, the positive, negative, and steady indicators are reflected on here, as well as the COVID-19 indicators we selected. And I think, what I'd love to do for the remainder of the meeting is answer any questions and then discuss potential updates to the system dashboard based on our adjusted strategic priorities and the board's interest. Any questions on this slide or the indicators I reported on?
Thank you, Jose. Any questions?
I mean, I see some of them deepen a little bit, but I mean, given everything that we went through, I mean, it's pretty impressive actually. For example, A1Cs didn't change that much, and even the ones that are connected to quality of care, they're pretty flat or changed by less than 1 percentage point. So that's pretty impressive given everything we went through. Thanks.
Thank you.
Thank you, Jose. Sally?
Yeah, I just echo what Jose said.
Good, Sally. Frida?
Can I echo too?
Thank you, Frida. I have a comment. I know I sounded like a broken record. I feel so sorry that I have so many comments. One of the things that, as you were looking and reporting, particularly now during the COVID and the decreases, can you go to the slides that shows the decreases in April 1st to June 30th? I find that sometimes it's helpful to have benchmarking. We are in a city that we do have significant number of other systems. And I have asked that question before. I'm not clear how much collaboration on data sharing are there across the different systems. And I don't mean only public, I also mean the kind of voluntary health systems. How are we doing compared to theirs? Do we follow the same pattern in terms of the reduction? Because I have seen how much the kind of the privates have emphasized e-consults when you were not able to go and see the doctor. They really were pushing it out there to continue that connection. I believe that we did the same, but it will be good to know how do we perform compared to them. I don't know if that is possible or is that the type of data that we may be able to collect from our sisters' health systems in the city.
I would say it depends, right? The closer it gets to financial information, the less we'll get.
Okay.
But some of it is certainly available. I think there is good collaboration on quality improvement measures in particular. On e-consults specifically, right, which again, an e-consult is from a primary care doctor speaking to a specialist. That I think is mostly kept internally by other systems, but I can check into it. For the overall telemedicine volume,
Yes.
the sheer amount of business that shifted to telemedicine, that may be something that the private systems did report, and we can compare to. I think, again, adjusting for the unique features of our patient population versus really any other system, we try to compare to other safety net systems around the city, but even then, I think that adjustment would be critical. But again, it's a great point, and we will try to point out where we have those benchmarks already and how we stack up. Anything you would add, Eric?
Yeah, and there are certain kind of statewide initiatives, sepsis being one of them. So we know that we have outperformed the state kind of benchmark, quarter over quarter there. Some of the core measures, we use Premier, but Vizient is another vendor. It allows you to benchmark, and you can say like only large systems, only large public systems, and be able to benchmark that way. And then, Greater New York Hospital Association and Haney's, they have these performance improvement kind of initiatives that everybody signs up for together. The kind of challenge of using publicly reported data is the delay, right? If we're just looking at CMS data, there's a huge delay there. But no, it is a good point, and we try to benchmark it wherever we can, and using all the sources available to us.
I think that would be great. And maybe, in the strategic priorities, as you are discussing the KPIs that you're going to be using for those strategic priorities, maybe highlight the ones that could be benchmarked, even though there is a delay. I always find that some information is better than no information, and even though it's delay, it still allows us to be more informed, because sometimes we tend to become parochial and myopic and only looking at what we do, but we don't know, what others are doing that may help us stretch a little bit more. And then we have a great partner in the Chicago Cook system, so we can talk to him.
Yeah. But just one example of where we are making these part of the discussions, and we could probably do a better job of incorporating it into this committee is what Kim just gave the update on, 41% for my chart activations.
Yeah.
The national average is in the low 30s, right? And the kind of stretch or kind of the model is Kaiser, right? And they're in the 80s. And so, right, that gives you some context. We've already beat the national average. Now we're, reaching for
Let's
Kaiser.
go after Kaiser. Good. Any other questions from any other board members? If not, I think that will conclude this meeting. Is that correct, Colisha?
I think Kalisha stepped out. In terms of timing, we probably are at the end of our hour. The only thing is at the end of the document, if folks want to discuss at a different setting, we have some proposed changes to the metrics for the committee based on feedback from board members. So happy to convene in a different setting, or if folks want to conclude, or we could discuss these.
I think Frida has a comment. So let's hear Frida, please. Frida, go ahead.
Okay.
Thank you, and Fenny and Matt. I think that's actually what I was going to say, Fenny. I did want to go through some of the dashboard and proposed changes and try to understand how they tie to some of the strategic priorities we've talked about, and some of it is I see the recommendations. I think they're good, they make sense, but I don't necessarily understand how to translate that into what we're trying to achieve. And then I feel that maybe there are some that we're not capturing. And I just wanted to have a discussion about that. I think that's going to take a lot longer than the minute or what's the right forum to carry on that conversation.
I think, Frida, I believe that, I also will be interested in looking at the metrics in detail. So maybe what we can do, and Jose, if it is okay with you and Sally, maybe we can ask Alicia to convene another meeting just to look at the metrics and the priorities and the interconnection and relationship between priorities, metrics, and pillars and goals. And so we can dive very deep into that, and maybe we can make that a 90 minutes so that we don't feel the pressure of rushing through anything. I don't know if you will agree, Frida, with that to do. Yes. Jose, are you okay?
Yeah, let's coordinate with Colicia to see what is the best format that she can, given what's going on until the end of the year. But I do think that going through, have some comments like you all do connected to, most of it is like philosophically, why are we looking at this measure compared to this one? Should we have, for example, IT is the one that I was looking at more carefully. And now that we have invested on Epic, maybe we should have more measure connected more, like how are we using all these investments?
Yeah.
Things like that. So yes, so Colicia will help us then coordinate on that. And
So we don't have time to go over this proposed changes, updates. And so Fanny and Jose were suggesting that maybe we could set up a separate forum for a deeper discussion, but we have to follow all the rules, the board rules.
We have to. Okay, we'll have to do it in a public session with the board members, and I'd look at the schedule and try to figure out if we could do something this month. What were you thinking about the timing, this month or next month?
I think, what about if we talk a little bit offline? I know that everybody has a lot of things happening at this time, but if you can follow up with us. But I think it would require a little bit longer time, 90 minutes, because I know that the discussions will go very in depth. And then we will follow your lead on what is the appropriate format and timing. Is that okay, Kalisha?
Yes, that's okay. Thank you. Okay.
Okay. Sally, are you okay with that plan forward?
Absolutely.
Okay. So again, thank you both, Matt and Eric. I really appreciate it. You have done an incredible job as always. Very impressed. And the only problem with that is that when you do such a great job, you just get more job, more work. So that's what happens.
We're ready.
Except not in our drawing.
You can go
Okay.
on the road.
So I guess now we are going to your meeting, Frida. It's your finance meeting. Is that correct? So now I can sit back and just watch.
All right. Thank you,
I
everyone.
think it's
Bye-bye, everybody.
getting more. Bye.
Bye. Okay,